for athletes or individuals at particular risk of recurrent tear, and these factors are evolving, but high level, high demand cutting, pivoting sports, hyperlaxity, a high grade pivot shift, or rotational instability to the knee. Very commonly, we are adding a lateral extra-articular tenodesis or lateral extra-articular reconstruction to our ACL surgeries. While the anatomic placement and biomechanics of anterior cruciate ligament reconstruction have become extremely precise and reliable, and in cases like mine, biomechanically validated by research studies I've performed in a biomechanics lab on my ACL reconstructions, the native ACL has an extremely complex three-dimensional array of fibers that a tendon graft just can't quite recapitulate. And there's often subtle injury to the other structures in the knee. The high forces it takes to tear the ACL apart will cause other trauma to other parts of the knee, including the anterolateral structures. So adding a second reconstruction on the outer part of the knee where the rotational instability takes place is showing increasingly in studies to reduce the risk of recurrent tear. So athletes at risk of high tear and people who are having revision surgery, for example, if this is your second go around with an ACL, may be candidates for a lateral extra-articular tenodesis or lateral extra-articular reconstruction. The good news about adding the LET is that while it adds a little bit of time in surgery, and in many cases reduces the risk of recurrent tear, does not affect the rehabilitation and does not seem to be a cause of any increased complication profile.